Hey everybody, welcome to our second webinar. How are you all doing? I'm doing fine, thank you very much. I know this is a weekday, and for those of you in US and Canada, it might be sort of difficult to make it to the webinar at this point, but thanks for coming online. Um, All right, so without any delay, let's get started. Just want to ask you, how's your preparation going? Are you all in the prep mode right now? Are you all? Yes. Okay. So Sarah says yes. I know, Sarah, your exam is coming up. I believe it's on the 13th. So your timeline is really short. And El Marie says it's going on as planned. Good. That's great. Okay. So let's get started. Okay, so this is our second module. It's health data analytics. Okay, this is a really fun module and it's also very dense. So I need your full attention today so that you can get the best value out of this. This is, sort of a continuation of the live webinar that we had done a few weeks back. Okay, because we're going to deal with data. Um, just to give you a sense of where we stand now, health data and analytics accounts for about 30 questions plus 4 research questions. So in effect, you will be dealing with 34 questions, out of which 8 will be recall. These are pretty straightforward, and that's what we are going to spend the first half of our webinar today on. And then you have application questions, about 19 of them, which includes not just data questions or math sort of problems, but you could also have application of various concepts that we'll be discussing today. And then you have around 7 questions that deal with analytics. Okay, so that's the split for health data and analytics. What are some of the important concepts we'll be discussing today? Some concepts, confidentiality, we'll be talking about that, developing and selecting measures, sampling methods, concept of benchmarking, data management systems, statistics and statistical process control, data tools, and interpreting data for decision making. Now, I want to just tell you, if you look at the live webinar that I did, plus Duncan's data deep dive course materials that I'm offering you. It's part of the bonus materials that you get when you registered. And then if you go to YouTube, if you go to my YouTube channel and if you look at some of the videos there, that will also give you a good sense of some of the concepts. Okay. Again, just a quick recap of how we are handling this. With the 2015, there is the 2015 content outline and the 2018 content outline, and most of the stuff in the 2015 outline is covered in the CPHQ Essentials course. And the rest of it is what we'll be covering on these live webinars. Okay, so what are we going to cover in this webinar? Any new concepts and materials according to the updated outline. I'm just going to reinforce some of the most essential content, help you understand the role of healthcare quality professionals in every context. You must learn what kind of questions can be asked pertaining to each subtopic that is covered here. And a full comprehensive review is offered on the CPHQ Essentials course. Okay, again, ground rules, you will be in mute mode, but you can put in your comments as we go along. If you have any additional questions or clarification, feel free to email me. If your questions are more detailed, I would wait till the Q&A call so that we can discuss those questions during the Q&A call. Sarah has asked a question. Can you send me your YouTube link? Sarah, if you just type in CPHQ Mastery on YouTube, you will be able to find the channel, and there are I believe about 8 or 10 videos on some topics that I've done, and you can you can find them there. Okay, welcome, May. So I have a few people here. Some of them have already, some of our group members had already excused themselves because it's a weekday and they're not able to join. Okay, now let's dive right in. As I mentioned, the first of our webinar is all theoretical concepts, and we are going to do a quick run through all of those topics. They're pretty straightforward. It's very material dense, so you just need to remember those concepts. And if you after we are done with the webinar, if you review these slides, you will get a good sense of those topics, and that will help you to answer any application-based questions. So the first thing we'll talk about is do a quick recap of the history of quality. Okay, so there are four stages. The first stage is early quality, when quality was not even a concept. This was when this was before the Industrial Revolution, when we relied on artisans and craftsmen, and the best method of ensuring quality at that stage was through inspection. Then we came into the Industrial Revolution, where mankind actually developed mass production of stuff. And when during this period, we relied a lot on having specifications for the goods that we were manufacturing, and then to inspect those materials after they were produced. Okay. Now, because of World War II, there was a huge need to produce goods, massive amounts of goods in a very short period of time, and that's when quality started going down, and at the same time you had to ensure quality. And so that's when some of the big principles of quality improvement emerged, key among them being statistical process control or statistical quality control. It was developed by Walter Shewhart. He was an engineer with Bell Labs at the time, and he was the father, so to speak, of statistical process control. Okay, and then post World War II, really the quality movement began in Japan, because Japan was trying to rebuild itself after the World War II, and that's where many of the concepts of quality started taking roots. So what are some of the quality strategies that came out of Japan? There were some foundational principles that they applied. Okay, the first one was that quality is led by upper managers, so they have overall responsibility and accountability for quality. You need to give quality management and quality improvement training at all levels of the workforce, starting with the worker on the factory floor right up to leadership level. There should be a focus on continuous quality improvement. That is the only way you can ensure quality of goods. And finally, there is this concept of a quality circle, where employees have a key role to play in making decisions about the quality of goods, and also to solve any problems related to the quality of the goods produced. Okay, so four key principles that the Japanese used, and then you are probably already familiar with all these concepts that came out of Japan. Okay, you have Kaizen, which is continuous quality improvement. You have the whole lean movement that came out, the Toyota production system. All of these came from the Japanese methodology. Okay, now, so what is the role of health data analytics and information systems? Okay, we are in this era where there is a huge amount of data being generated, in not only in healthcare but in other industries as well. Now, how do you make sense of that data, and how do you put it to good use? That is the whole concept of health data analytics. There are some major drivers in the healthcare industry of health data analytics. In the 1960s, data was relied on by Medicare and Medicaid to make the decisions about who should be getting the reimbursement. In the 1970s, there was in the process of breaking down silos between different departments within a healthcare system as well as across healthcare systems, data began to be very important. Okay, also because of the application of epidemiological principles, which we'll be talking about later. In the 1980s, there was a huge focus on reimbursement, the whole insurance industry, and usage of diagnostic related groups. Okay, so data had to be used to decide on the reimbursement. And in the 1990s, because there were so many mergers and acquisitions between several hospitals in the United States, that led to the emergence of these huge monopolistic healthcare systems, data was, the decision makers are very reliant on data. In the 2000s, the whole shift happened to value-based care and also outcome-based reimbursements. And so health data analytics got a big boost because of that. Now, What is big data? Basically, big data just means, any organization that operates at a certain scale generates a vast amount of data, and that you have that data coming from several different sources, and you need to make sense as a leader, as a healthcare quality professional. You need to make sense of that data to make key decisions in the delivery of care. Okay, so right now it has assumed more importance because of the emphasis on population health. We are trying to improve the health of population. Remember, there is something known as the triple aim, which has gained new significance because of the Accountable Care Act. Okay, what's the triple aim? There is the first aim is improving patient experience, second one improving the health of populations, and the third one is reducing cost of care. Okay, so because of all these, data becomes very important. Now, there are four characteristics of big data. Anyway, this is good to remember because you might get a question on it on your exam. What are the four characteristics? First one, the sheer volume of the data that we are dealing with. Okay, because of the size of the healthcare system, and because of the capability we have right now for generating vast amounts of data. Okay, because of technology. Second one is the velocity of data. So in healthcare, it is important that you get data in real time so that you can act on it quickly and then make the corrections or the improvements necessary. Third one is the variety of data. You can look at a single problem from different angles. Okay, you can collect data from several different sources, and that can be used to make accurate decisions. And finally is the veracity of data. This basically means the accuracy of the data, that whether you can really rely on the data that you are collecting. So big data has to have these four characteristics. Okay. Now, electronic health records and health information exchanges provide large data sets. That's what healthcare systems rely on. But there are some factors that can make or break this exercise of converting data into useful, actionable information. So what are those factors? First thing, it can be impeded if you don't have the appropriate tools for analyzing the data and converting into information. Second is the accessibility of data. Are you able to access the data that you require? And the third one is, do you have the right kind of people who have the adequate amount of training to be able to use this data in a meaningful manner? Okay, so three factors that affect the conversion of data into information. Now, the Institute of Medicine had a committee on patient safety and health information technology, and basically, it came up with a bunch of conclusions about the use of data for promoting patient safety in healthcare systems. Okay, so what are these? What were these conclusions? First thing is that safety is actually a function of an interplay of the software that you use, that is the technology that you use, plus how the clinicians are using it. So it's basically humanware and software interacting with each other. That is what creates safety. Okay, second one is the whole socio-technical system that is in operation in a healthcare system includes a few factors. You have people, you have technology, you have the various processes, clinical and administrative processes that you run, you have the whole context of the organization, and then all that is working within the context of the external environment, like we mentioned in our previous webinar. The government, the payers, the community, all of these. And safe implementation and use of health information technology is basically a shared responsibility between vendors and healthcare organizations. Patient safety can be threatened because of poor user interface design. So if the technology that we use is not user friendly, that can also affect safety. And if because of poor workflow, if it is not smooth to use, and if the data that is generated is of a complex kind. Okay, clinical decisions and patient safety are affected because of lack of system interoperability. Meaning, how easy is it for you to transfer data from one system to the another, or from one location to another? Okay, that can affect clinical decisions and patient safety. And constant ongoing commitment to safety is needed, especially from leadership. Okay, so these are some of the conclusions that came out from the Institute of Medicine report. Now, let's talk briefly about the health information technology for economic and clinical health Act. Okay, so this was part of the whole American Recovery and Reinvestment Act that came about in 2009 as part of the whole, the stimulus package that the US government came up with after the economic recession. Okay, so Health Information Technology for Economic and Clinical Health Act. So what they did was they decided to provide a stimulus by spending to promote and expanding the adoption of health information technology. So basically, there was a bunch of monies that was devoted towards encouraging health systems to adopt information technology. And interoperable electronic health record adoption was established as a critical national goal. In effect, basically, they established it as a priority for health systems to move from paper-based systems to electronic systems. All right, and there were incentive payments for Medicaid. Are you all able to hear me? Sadia says the voice is lost. Are you all able to hear me? Yes? Okay. So I was saying there were incentive payments for Medicare and Medicaid providers that adopted electronic health records. Okay. So there were some monies that were set aside as incentive for adoption of health information systems. Okay. Now, what the incentive money was actually given for what they defined inside the act as meaningful use. Okay, meaningful use of technology. It's important for you to remember what the term meaningful use means. Okay, meaningful use means use of technology to improve quality, safety, and efficiency, and to reduce disparities in care, to use of technology to engage patients and families, use of technology to improve care coordination, population health, and public health, and use of technology to maintain privacy and security of patient health information. So this is what is defined within the Act as meaningful use. Okay, you could have an application question of this. They could give you a bunch of options and say all of these are examples of meaningful use except, and you have to choose which one doesn't fit the criteria. All right, so that could be one example of a question. And then what was intended as a result of this meaningful use? It is assumed that if the organizations comply with meaningful use, it will lead to better clinical outcomes, it will lead to improved population health outcomes, increased transparency of care and efficiency of care, it will result in empowered customers, and it will also generate more robust research data. All right. And it was meant to be implemented in 3 stages. The stage 1 was to happen in 2011-12, where organizations were contributing to data capture and sharing, leading up to stage 2, where it will lead to promotion of clinical processes by 2014. And finally, that should result by 2016 in stage 3, that is improved outcomes. Okay. So on this slide, the first two things are more important, like what is meaningful use and what would be the result of meaningful use compliance. Okay, straightforward concepts. Okay, now what are some characteristics of data quality? Okay, first thing, the data that is generated in healthcare must be accurate. So basically it should reflect what we are trying to understand. Second, it should be accessible, so it should be easily retrievable from the system. Third one, it should be comprehensive. Basically, it should answer all the questions about whatever it is that we are trying to learn. Okay, it should be consistent. So, regardless of the tool that is used and regardless of who is going to measure it, it should give consistent, reliable data over time. And currency of data, meaning the data should be up to date. Then definition of data. So there should be clear, easily understandable definitions about each data point that we are collecting. Then granularity of data. That means it must give you the level of data that is appropriate for our use. Okay, so that means it should give enough level of detail about the data. The precision of the data, it's basically it should not be too large or too small. It should be of enough size for us to take good action. And relevancy of data means it is basically appropriate for whatever it is that we are trying to study. And finally, is the timeliness of data, basically that you should be able to retrieve the data as and when the decision has to be made. So it must be retrievable quickly. Okay, now how does data help leaders? Again, so this slide, how is it useful? Again, you could have a very straightforward application kind of question. They could ask you all of these are characteristics of data quality, except, and they could give you one option that does not fit. Okay, so that's how these questions are framed. So how does data help leaders? It helps leaders in three things. Okay, first is delivery of better care. Second one is spending your budget smartly, and the third one is resulting in healthier people who come through your system. Okay, how does it promote better care? Basically, you could look at your mission and vision and see and decide which data points will help you to deliver on your mission and vision, and then track those data points. That's one. Second one is you could look at the quality of clinical care that is delivered. So you could look at various clinical conditions and look at how well you're doing for those clinical conditions. And the third one is performance improvement of your hospital. So basically the efficiency of care, the timeliness of care, uh, all those things can be monitored. Smarter spending, again, you could decide what your strategic priorities are and make sure that you're allocating resources accordingly and appropriately. So again, data can help you to make those decisions. And finally, you can have healthier people basically by looking at the entire community and the data related to that community which you're serving. Okay, so this is how data helps leaders. Again, that can be a very straightforward question. I think these are all common sense ideas. So this is just for you to recap, and you can always go back to these slides and review them, and so that these concepts stick in your mind. Yeah. Okay. Now, there are 7 basic concepts of information related to quality management. Okay. What are those 7 basic concepts? Again, good concept, useful concept to remember. First one, the information that, what do we do with data? We analyze the data and then we convert it into meaningful, actionable information. Okay. Now it's important that you define the data, collect the data, and analyze it in the full context of your operations, or in the full context in which your health system is operating, for it to be useful for you. Second is, it's important to remember that not all data and information is useful. Everything is not actionable. Third one, mature information comes from patterns, not individual cases. So an example would be if you take any one clinical condition and you have an outlier patient, okay, a patient whose results are off the charts, or who looks completely different from the rest of your population. What do you do with? So that does not give you a full information. Basically, you have to look at the entire pattern of all the patients within that clinical condition to make any sort of judgment. Okay, then the most of the quality indicators that are currently being used in healthcare systems are usually just, they only help you to understand the problem, but they're not true measures of quality. Then you need multiple measures, and they must be looked at in tandem in order to get a full 360-degree view of the quality of your care. Okay, so multiple measures are important. Just one measure about a certain problem is not going to give you the full picture. Sixth, outcomes information without process information is inefficient. Okay, so we will talk about the different kinds of measures, that is structure, process, and outcome measures, a little later. And finally, cost and quality are inseparable components. Okay, so these are the 7 basic concepts of quality management information. Now, what are the 7 steps of interpretation and use of quality of care information? First one, so again, see, this is the role of a healthcare quality professional. Okay, planning and organizing for data collection, interpretation, and use. Okay, so this is a job. So the first thing is that you plan for why you are collecting this data, and then organize the data collection effort. Second is, after you have collected the data, you verify it and you clean up your data so that you are able to retrieve good actionable information. Third, you identify and present potentially important findings. So this is findings that must be reported to your leadership. You can also analyze how this data compares to other departments in your organization, or to other hospitals that are comparable. Okay, how are you performing over a period of time? Are there actions that you can take to improve it, etc.? Okay, so this is how you present your findings, and then basically you use that same data to monitor your performance over a period of time, and based on the monitoring, if you see any variation, you can develop some recommendations. Finally, you take action. So basically, what sort of, based on the data, you can decide what sort of action is required. Do you need to educate your people? Do you need to have some quality improvement initiatives floated? Do you need, what else can you do? Do you need to bring in some outside educators into the department to help you to improve? Finally, as a healthcare quality professional, you'll continue to monitor performance after you have taken the actions. Okay, so to understand if those actions have resulted in some meaningful improvement, and if they have made some meaningful improvements, how are you able to sustain it? And if you're able to sustain it, how are you able to spread it across different parts of your hospital? Okay, and then the final one is communicating your results. Communicating results will happen within the organization to all levels of the staff, communicating it to the leadership team, communicating it to the board, and also communicating it, let's say, to the CMS, to Joint Commission, to other agencies of the federal government, all of those, right? So you should decide how you're going to communicate those results. Okay, now let's talk about quality measurement. Okay, so there are 4 criteria for process measures. So remember, I said you have outcome measures and process measures. What is the difference between both? Let's say I'm looking at reducing pneumonia in my community acquired pneumonia in my population. So the number of community acquired pneumonia cases would be an outcome measure. Okay, so I want to reduce that. What would be a process measure? How can I achieve a reduction in community acquired pneumonia? Probably by giving pneumococcal vaccine, vaccinating the people who come to my clinic, for example. So that would be a process measure. Okay, now it's important to understand there are 4 criteria for process measures. Okay, remember, this could be another question on your exam. First is, there should be a strong evidence base that shows that this particular care process leads to improved outcomes. Again, in our example, there is strong evidence that vaccination will reduce the likelihood of community acquired pneumonia. Second, you are able to measure accurately. Basically, the measure accurately captures the provision of evidence-based care. So basically, you have a literature to fall back on to say that this is the evidence on the basis of which we are doing this. We are measuring this particular process. Third one, the measure addresses a process that's adjacent to the outcome, meaning it is something that can be tied immediately to the outcome. Okay, it is not something far off. Basically, what that means is, if you give a vaccine, for example, the vaccine immediately starts to positively affect your body. Okay, it helps to build your immunity immediately. It's not that you vaccinate and then after a period of 10 years you develop the immunity. So it is close to the process. And the fourth one is the measure implementation has little or no chance of unintended adverse consequences. Okay, so little chance of unintended adverse consequences. So these are the 4 criteria of process measures. Okay, now let's talk about the concept of risk adjustment. Again, very important from a CPHQ point of view, and you can expect a question on risk adjustment. So let's talk about that in detail. So why risk adjust? So when you're collecting data, you need to risk adjust your data. It's based on the assumption that different patients with the same diagnosis may have some additional conditions or characteristics that can affect how well they respond to treatment. In other words, I can have two patients let's say I can have two patients of asthma. Okay, I can give the same treatment to both those patients, but one may respond well and the other may respond poorly. Okay, that's because both of them within themselves, they have different factors that are affecting how they respond to the treatment. So this is the concept of risk adjustment. Okay, statistical techniques control for these characteristics or conditions. So basically, when you collect large amounts of data, you have to adjust for the different risks for those particular conditions. And I'll give you some examples as well. Now, it helps to remove the bias effect. Okay, usually why that happens is, let's say you have two physicians. Okay, you have physician A and physician B, and your let's say both of them treat patients of asthma, let's say. Okay, so both of them treat patients of asthma, and you're trying to see, you're comparing their results, the clinical outcomes, or clinical outcomes for both of these physicians. Now, one physician may say, oh, but my results are not good because my patients are sicker. Okay, so in that case, what you have to do is you have to risk adjust his patients. Okay, so that both the groups of patients can become comparable, and then you can make a true judgment about whether any one physician's patients are sicker or not. All right. Okay. Now, what are some of the factors to consider during risk adjustment? Okay. Now, the accuracy of your model. So basically, healthcare organizations use various risk adjustment models. Okay. The accuracy of these risk adjustment models is based on two factors. The first one is the kind of risk factors that you include within the model. Okay. Depending on how comprehensive it is and how exhaustive it is. Second one is something known as a concordance statistic. So this is a statistical measure. Just remember this name. It might help you in a recall question. Concordance statistic basically tells you the predictive accuracy of the risk adjustment model that you have used. In other words, how accurately does it help you to predict the clinical outcome for a particular condition? Okay, so if I apply this model to the next patient who comes into my system, how accurately is it going to tell me if my treatment will work on that patient or not? Okay, so it's known as a concordance statistic. Okay, and then also this is a role of healthcare quality professionals. So healthcare quality professionals must decide or must advise the leadership team about how we are going to handle statistical outliers. So there must be a statement within your risk adjustment model that tells you how you're going to handle your statistical outliers. Okay, for example, again going back to our case of asthma, if you have one patient in your group of 100, if you have one patient who is extremely sick, okay, and because of that one patient your entire data is skewed in any one direction, how are you going to handle that? So that is a decision that needs to be made in terms of data, and this is where the healthcare quality professional must come in. Okay, and the level of detail you can use, you must, again, in your risk adjustment model you need a certain level of detail which must include not only the clinical factors but also some financial factors. So you can drill it down to look at the financial factors as well for every payer, practitioner, and patient. And it can be you can use this risk adjustment model to mine data for benchmarking your quality performance. You can use it to compare physician performance. This is the example that I gave you earlier. Okay, you can basically go down at the patient level and look at the various details and compare it against your risk adjustment model. And you can also look at individual patient information, and you can use this risk adjustment model to determine the impact of managed care. Okay, so is it bringing about, especially this is applicable more to chronic care conditions, right? So for example, like asthma, heart disease, diabetes, all these cases. And also for analyzing your clinical services for the effectiveness of care. So if you use the concordance statistic, and you can decide if based on the risk adjustment model, if you institute a new kind of care for a certain clinical condition, is that really effective for your patient population? Okay, now you have to compare risk adjustment against another concept known as severity adjustment. Now, let me try to make it clear to you. What is the difference between risk adjustment and severity adjustment? Let's look at Unit A and Unit B. For all practical purposes, Unit A and Unit B are very comparable units, okay? they they're very comparable. They are almost equal in many factors, but I find that unit B has a longer length of stay. So LOS is length of stay, has a longer length of stay for its patients who are admitted in unit B compared to unit A. So now I'm thinking, okay, now why is that? Now both of them are identical in many respects, but why does unit B have a greater length of stay? When I dig deeper, when I use my risk adjustment model, I find that unit B has more number of diabetic patients. Okay, so they have a chronic condition, and that is why unit B patients have a longer length of stay. So now what I do is I risk adjust the comparison between unit A and unit B using diabetes as a factor. Okay, once I risk adjust for diabetes, then I'll be able to make a more accurate comparison between the length of stay of unit A and unit B. Okay, so that is risk adjustment. Now let's look at unit B and unit C. Okay, again, unit B and unit C are both comparable in all respects. So I find that unit C has an even longer length of stay compared to unit B. Okay, now I find that both of them have diabetic patients. Both of them. So it's like they have the same number of diabetes patients. Okay, now, why is that? So, why is unit C having a greater length of stay here? It's because of the severity of diabetes of the patients in unit C. So, even though they have the same number of diabetic patients, they have sicker diabetic patients in unit C. Okay, so now what I've done is I have severe, in addition to risk adjustment, I've also adjusted for severity. So only if I adjust for severity of diabetes will I be able to compare unit B and unit C more accurately. Does that make sense? Okay, so now let's come to the concept of evidence-based practice. Again, pretty straightforward concept. Evidence-based practice, basically, it's about the use of the best evidence when you're making decisions about the clinical care that is provided to your patients. Now, the term evidence-based practice is earlier we used to use the term evidence-based medicine. Okay, but now we moved to using evidence-based practice. Why is that? Because care and decision making by clinicians is a function of several different factors. What are those factors? First is the experimental evidence. So this is the evidence that comes from research. Experiential evidence of the clinicians, the skills and the knowledge of the clinicians. Physiological principles of the patient and professional values, and also the system features. So the system, the features of the healthcare system in which this care is being provided. Okay, so evidence-based medicine basically would only allude to the clinical evidence that we are getting from research and literature. Okay, evidence-based practice encompasses all these different principles. Remember that. Okay, now epidemiology. Anyone here with a background in epidemiology or biostatistics or anything? Anyone who has been involved? Anyone has an MPH here or masters in public health? Okay, so what is epidemiology? Basically, it's the use of large data sets. Okay, so data from a huge sample of the population. Okay, it is basically used in research. You may know. Uh, and basically if you use epidemiological principles, you can avoid any selection bias. Okay, so you can compare different groups, you can compare comparable groups, right, across different geographies, across different regions. And also it augments the use of statistical methods to make judgments, okay, of about the data. And more robust analysis and quality and performance improvement using epidemiological principles will actually lead to wider acceptance and broader adoption. Okay, because there is some scientific evidence behind whatever you're suggesting and behind your analysis, it's easier to convince people. It is easier to convince the leadership that you have some scientific backing behind the analysis that you are providing. Okay. Now, the concept of population health, it is defined as health outcomes of a group of individuals, including the distribution of these outcomes inside the group. Okay. That is a concept of population health. Now, population health management or population medicine, as it is known, what is the definition of that? It is the design, delivery, coordination, and payment of high quality healthcare services to manage the triple aim for a population using the best resources available within the healthcare system. Okay, just read that definition, get the overall gist of what that definition stands for. That's all you need. You don't need to memorize it or anything. Remember what the triple aim is. Let me just recap it for you. I also mentioned it earlier. Triple aim is improving patient experience, improving population health, and reducing cost. Okay, so that's the triple aim. Are you all able to hear me? Yeah. Okay. Sadia, you might want to check. You might want to check the technology at your end because it looks like you are facing some problems with the audio. So just make sure your Wi-Fi connection is okay and all that. Okay. Sound okay now? Yeah. Okay. All right. And population health actually becomes more and more important. Okay, the robustness of your data analysis becomes more and more important. As we have said, we are moving from a volume-based to a value-based care. I've already defined that in our previous webinar. And how should healthcare organizations use this concept of population health? It is useful in risk management and in utilization management, in the management of utilization of your resources. Okay, now let's come to the concept of information systems. Let's talk in detail about information systems. Okay, information systems are all those technologies that you use to gather information. So factors leading to effective information gathering and dissemination. What are those? First, identify who needs your information, determine what amount of information is needed so that you can improve quality of care. Okay, make sure that the right people get the right information at the right time in the right way. Okay, there are different categories of information systems within a healthcare organization. First, you have clinical information systems, then you have administrative information systems. Administrative would include financial and human resources information systems. Then you have imaging information systems, you have human resources, you have finance, then you have patient experience information systems. Okay, and then you have decision support information systems, and we'll talk about each of these in detail. Okay, so the key principle about information systems is that it must support quality and performance improvement activities such as measuring, tracking your data, sharing your performance measures across various stakeholders, and also it should help you to track any improvements that you have made in your clinical workflow process. Okay, and you must also be able to monitor any effects of change on your patient experience and care coordination. So those, so information systems must actually satisfy all these different needs for an organization. Okay, it must help you to reduce your cost and improve patient health outcomes. Now, in deciding about information systems, organizations have two key decisions. We can have a key decision to make, whether they should build the systems in-house or whether they should purchase it from outside. Okay, so how do you? What are some considerations if you're considering building in-house? What are some things to keep in mind? First thing, do you have the required expertise? Can you make the right investment? Do you have the skills and knowledge in-house to implement that system? Do you have the capability to get ongoing staff input about improvements and refinements? Is it possible for you to sustain it using the resources that you have in-house? Do you have resources for updates in the future? Okay, do you have a clear understanding of what sort of data you will require in the future, and are you able to make tweaks to your information systems accordingly? Are you able to dedicate resources in the long term for this? Okay, are you able to participate in a vendor network? And is it cost effective for you to excuse me, build it in house or to purchase it? Which would be cheaper and cost effective for you? Okay, so these are some considerations. Again, this could be an application question on your exam, so just have a read of these factors. Considerations for purchasing. Now, if you're considering purchasing, what are some points that you need to keep in mind? First thing, these are some questions that you will be asking the vendors, right? Again, this is a role of healthcare quality professionals. You may be involved in making that decision or in advising your leadership team about the decision. Okay, so just excuse me for a moment. All right, okay. So the first one is the question about capturing, storing, and retrieving your clinical and financial information. Does the new system that you're purchasing interface well or align well with your existing information systems? Does it allow for triggers or thresholds? Okay, any alerts in the system? Does it have critical alerts? Remember, there are alerts built for various kinds of clinical conditions, for example, for sepsis. Okay, then does it have rule-based processing or algorithms? Okay, that clinicians can use in decision making. Does it allow for retrospective reviews? Does it support your accreditation and regulatory requirements? Okay, does it have a capability for data reporting and statistical analysis? Okay, does it allow for multiple users simultaneously? Remember, sometimes you have people who are working remotely, so they may want to access the system remotely. Does it have an open operating system, or does it have any specific requirements? Okay, are there networking capabilities? Does it produce data in graphic form? Does it allow for a drill down analysis of the underlying causes of the outcomes? Okay, and is it possible for you to access the report via internet? So these are some of the factors. Again, you don't need to memorize them, just have a read through. They're pretty straightforward and common sense, and you should be able to answer any common sense questions that come out of it. Okay. Okay, now let's talk about each of these information systems in detail. What are administrative information systems? These are the things that you use for your day-to-day operations. Okay, so financial software, human resources, for example, you might be familiar with Oracle. Oracle has certain administrative information systems. Office automation systems like Microsoft 365, for example. Then you have management information systems. These are used for decision making. They're also known as medical information system, hospital information system, decision support system. What are they used for? They are important for establishing the overall goals and priorities based on your strategic plan, for allocating the right kind of resources, to even for your budgeting purposes. You need it to evaluate the performance of your quality and performance indicators. Okay, and it is required for monitoring any system within your clinical operations. Okay. Now, third one is clinical information systems. I'm sure you might be familiar with Cerner or with Epic Care. These are your clinical information systems. Okay. These support direct patient care processes. Okay. And these include your electronic health records and their retrieval, any computer-assisted medical decision making, antibiotic selection, etc. That's one of the key ones. Okay. Algorithms that help in antibiotic selection. Then clinical application for health risk programs, health maintenance organization, encounter data, okay, data that you'll be sharing with various managed care organizations or health plans, any clinical algorithms. So, you could basically build your clinical pathways into your clinical information system. The use of predictive modeling, again, for data, for clinical conditions, and to run simulations before you actually go live with any particular clinical service. You could run simulations using these clinical information systems. Okay. Fourth one is decision support systems. What are these? These are basically for cross-functional analysis, okay, to improve your care processes and outcomes. And they are basically used at the higher level, at the leadership level, to address some strategic planning functions. What are those? You could use it again, to understand your data for planning and marketing your services, for budgeting and resource allocation, to evaluate the overall system performance. Okay, and you could develop some performance dashboards, which we'll be talking about later. Then to evaluate the performance and of your various clinical services and clinical products that you are offering to your community. They're used for medical management, like implementation of guidelines and pathways and evidence-based practice. Okay, and they're used to develop outcomes information management plan. And remember, you can put together clinical and financial data to help in your predictive outcome management. Okay, and so that will help you to evaluate your current services. Okay, and based on that, you can then develop new offerings. Okay, so basically, you're using the effectiveness of your various clinical processes, and you're also comparing that against the financial performance. And based on that, you can decide how effectively your current clinical services are working and what new ones you need to introduce. Okay, now let's talk about registries. What are registries? Two types that we are going to talk about today. The first one is disease registry. What's a disease registry? It's basically an information tool that helps you to track clinical care and outcomes of a defined population. So for example, for a particular country, you might have a disease registry, you might have a cardiovascular diseases registry, you might have diabetes registry, right? And basically it gives you an insight into the care management for chronic conditions. Okay, so it's basically about all those patients who it's a full large scale data about all the patients who have that particular condition. Now, another one is data registry. So basically, it's the health status of patients and healthcare that is received over a period of time. Okay. Um, and what are the uses of registries? Basically, you can observe how different patients respond to various treatments. Okay, within that registry, you can look at different clusters of patients and how they respond to treatments, and that can also help you in some predictive, predictive suggestions. Like you can inform patients and providers about what are the best treatment options for certain kinds of patients. Okay, so two uses there of registries. Okay, many of the other concepts that we are talking about here, some of them that we are not talking about here are also discussed on the CPHQ Essentials, so don't worry. I'm just talking about some of the updated concepts here. Okay. Third use, you can also compare the performance of different healthcare providers, okay, for the same clinical condition. Fourth, evaluate the care that is provided, and you can use it also for quality improvement. Okay, to make judgments about whether you need to improve or sustain or spread any quality improvement initiatives. Okay, talking about quality improvement initiatives. See, data is at the heart of any quality improvement initiative. Okay. Now, what sort of initiative should a healthcare organization have for quality improvement? First, your initiative must be related to your core processes, core systemic processes like admissions, transfers, and discharges. Okay, it must be or it could be related to your high risk processes like medication delivery or administration of medications. Okay, anything that has the potential to harm your patients. The third one, your initiatives can be related to the high risk patients that you deal with. So any chronic conditions, impaired renal function, immunocompromised patients, neonates, pediatric population, patients who are in the intensive care units, etc. Okay, you could have initiatives related to your high risk medications as well, medications that have a very small window of safety, like heparin, insulin, chemotherapy drugs, all of that. Okay, or your initiatives must be related to any high risk actions or interventions such as blood transfusion, use of restraints, extracorporeal circulation, etc. So these are all related to processes that have a potential for harming patients. So what are the key steps for conducting quality improvement initiatives? First, ensure leadership support. Okay, this must directly tie into the strategic priorities of your leadership. You must assess the priority of the initiative and the feasibility of running such an initiative in your setting. You must identify a specific aim, like what are you trying to improve and in how much time. Then based on the aim, you should convene an interdisciplinary team. So it should include physicians, nurses, it can also include allied health services, it must include a quality champion, it must include some data expert, and definitely healthcare quality professionals should be in there. Then you use all the different tools and techniques that we'll be talking in this module, as well as in the next module on performance and process improvement. So, quality improvement initiatives must follow some science. And so definitely tools and techniques are important there. You then develop some change ideas and you identify some measures. Actually, it should say identify some measures. So you should have some outcome measures as well as some process measures and some balancing measures related to your initiative. Then you must go about educating your staff about the initiative, then implement the change. Basically, you should first test the change on a small scale, try it out on a small scale and tweak it, modify it as necessary. Okay, then you go back and collect some data and you evaluate the data about how well your test went. And then based on that, again, modify your test. Then after that, as you make improvements, you will report and display the results like we mentioned previously to several different levels of the organization. You will then continue to monitor your performance so that you don't slip. And finally, you also need to compare your performance internally and externally. Okay, and the last step is that you celebrate your success so that people can be motivated to take up more quality and performance improvement initiatives. So these are the 15 steps of quality improvement, of implementing quality improvement initiatives in your organization. Okay, again, you can in my experience, definitely you will have one question on related to this concept, okay, about how to run quality improvement projects in your organization. And again, remember, this is a key role of healthcare quality professionals to facilitate this whole process of running quality improvement projects. Okay, now performance measures. There are measures of three kinds. You have structure measures, you have process measures, and outcome measures. So, what is structure measure? Structure measure basically tells you about the resources that you have and the capabilities that you have within the organization. So, let's take an example. Remember, we talked about the pneumococcal vaccination example, right? The outcome that you wanted was to reduce the incidence of community-acquired pneumonia, and to do that, the process that you chose was of vaccinating the population that comes into your organization. Okay, what could be a structure? Structure could be the availability of vaccines, availability of enough vaccine stocks, or it could be training your one other structure could be the skill level of your staff in administering the vaccine. I'm just giving some simple examples for you to understand. Okay, so you could measure each of these. So outcome measure, I would look at percentage of patients who come to my clinic with community acquired pneumonia. Process measure, percentage of patients who come to my clinic who have received the vaccine. And structure measure, availability of the stock of vaccines in my clinic on a weekly basis. Okay, so those are the three kinds of measures. Where do you get all these quality measures from? Remember, we talked about this in module 1. CMS is a good source. You can also get from the Agency for Healthcare Research and Quality, the AHRQ, or from the National Quality Forum. Okay, there was something known as the Impact Act. Okay, and it basically encourage the implementation of cross-setting measures. Okay, what does cross-setting measures mean? Basically, it's the subacute care that happens after across different healthcare providers, like long-term care hospitals, skilled nursing facilities, home health agencies, inpatient rehabilitation facilities, etc. Okay, so it requires submission of standardized data by all these different subacute care providers. And so basically it's to look at how the care is moving across different settings. Okay, some examples would be skin integrity, functional status, hospital readmission rates, etc. So just remember this, just you need to have a cursory knowledge of the Impact Act. Okay, how do you select performance measures? So for any particular clinical condition or for any particular improvement initiative, you can have a host of measures. So which ones should you have? Because you cannot track everything, right? So you need a certain set of measures for your sake. So let me pause right there. Is my audio okay? Okay. Okay, so moving on. So how do you select the performance measures? First thing, it must be important to your to your context. I'm sorry. It should be scientifically sound. Okay, so there should be some literature that backs up your selection. It should be feasible in your setting. Okay, so your resources, your staff, etc., should be able to collect this particular measure. It should be actionable. That means you should be able to do something with that measure. And you must also think about how you're going to standardize, so that the same kind of information is being collected and the same kind of information is being reported across different settings. The comparability of your results is very important. So remember, this is where the risk adjustment and the severity adjustment concepts come in. Okay, the availability of your data, very important. Timeliness of your data, it should reach you when it is actually needed, not after a year or 2 years. Okay, the relevance of the data for that particular priority that you are trying to track it for, validity of your data, um, the experience within your organization with the measure, so that you can actually measure your performance well, the stability of your data so that it doesn't change with minor changes in the system. Okay, and evaluability of your data so that you can measure the you can evaluate the measure from time to time, and the distinguishability, basically, so that it can help you to distinguish between different organizations performance. Okay, so these are some criteria. Just remember these criteria for selecting performance measures. Oh, and the final one is the credibility of the measures. So basically, they should be auditable. Okay, you should be able to go back and take a small sample, audit the sample, and make sure that whatever you're collecting is valid. Okay, some sources of performance measures within a healthcare system. You could look at your administrative data. You could look at your medical records. You can get performance measures from within your patient surveys, and you can also get it within standardized clinical data sets. So these are some sources of peer performance measures within an organization. Okay, what others can you use? You can use your safety culture surveys. You can use employee satisfaction surveys, patient satisfaction surveys, any sources of complaints or feedback that you're collecting from patients, etc. Right? So based on any or all of these data, you can develop performance measures. Just make sure that that measure is actually appropriate for your healthcare organization, and that it is feasible for you to collect, and it is relevant for your use. Okay. Now, before I go further, we are about halfway, and so let's take a quick 2-minute break, because I just want you to stand up and stretch, and maybe just, take some deep breaths because the next part is going to be about data. All right. So let's take a quick 2-minute break, and we'll come back. Okay, are you all ready to go? Ready to start? Alrighty, so let's get going again. So if you remember from our from our first webinar on data, we talked about two kinds of data. We had like qualitative and quantitative data, and within quantitative data, you had continuous data and discrete data. Okay, another way of classifying it or naming it is you could call it measurement data and count data. Okay, so continuous data is also called measurement data, and discrete data is also called count data. Now, what does that mean? Okay, let me give you an example. Okay, what is an example of a measurement data? If I measure your blood pressure, I get a systolic blood pressure and a diastolic blood pressure. Okay, I get a certain value for it. That would be an example of a measurement data. Now, I could classify that anybody above, anybody above 110, 70 is hypertensive, mild, moderate, or severe hypertension. Okay, so I can classify people as having hypertension or not having hypertension. That would be my count kind of data. So for the same kind of measurement or the same kind of variable, same kind of study, I can convert it into both measurement data and count data. Okay, now generally measurement data is considered to be more statistically powerful. Okay, it is more statistically powerful, and that's why count data, you need a large amount of data to get some statistical significance. Just remember that. Okay, just remember that. So for quality and performance improvement activities, generally, because of the ease of collection and because of the ease of analysis, count data is what is generally collected. Okay, and you would find that for research studies and for epidemiology and for population health, generally measurement data is more used. Okay, now as I mentioned, for count data, large samples are required, okay, in order to ensure their validity and accuracy. Okay, and you can basically use comparison groups if you want to eliminate the impact of variation between two groups that may not be equal. Okay, so you can use you can use some control groups. Basically, you can use some control groups, and there is this concept of propensity score matching. Okay, where basically if you're running an intervention, you could pair up people with the same characteristics in the intervention and the control groups. So for example, I know it is not done anymore, but generally if you have a new treatment for any particular condition, you give it to certain set of people who are the intervention group, and then you have control group who don't get that treatment. Okay, and based on same characteristics, you could pair up people in the intervention group and the control group to see for the same comparable kind of people, how does the treatment affect them and how does not treating affect them. Okay, so that is known as that is the concept of propensity score matching, right? Now let's talk about sampling. Okay, now I want you to take this slow and just understand the concepts here. I'll explain with the help of pictures. So there are different kinds of sampling. Okay, so sampling is of two main types. You have probability sampling and you have non-probability sampling. Now, what is the difference between both of those? Probability sampling basically requires that each point in the population that you're studying will have an equal chance of getting selected into the sample. Okay, so that is it, that everything has an equal probability of being included in the sample. That is why it's called probability sampling. Non-probability sampling does not have that sort of a scientific approach. Okay, there is no each point in the population does not have the same probability of getting selected. Okay, so you have probability sampling and non-probability sampling. Now, probability sampling is further classified into the following categories. What are those? So first, you have what is known as simple random sampling. So you have a set of elements in your population, and you randomly select samples from it. Okay, so that is why it is called simple random sampling. Then you have what is known as stratified random sampling. Okay, so basically what you're doing is you're stratifying the same population, you're stratifying into certain groups. You're stratifying into certain groups, and then within those groups, you're going to select one sample each, or X number of samples each. Okay, so for example, let's say I'm trying to study the heart disease. I'm trying to study heart disease in the city of Boston. So what I can do is within the city, I can select the population, and then I can basically stratify them, quote unquote, into different groups, like based on their age, based on their ethnicity, based on their profession, etc. Okay, and from each of those strata, I can select a certain number of samples. So that is stratified random sampling. Then you have what is known as systematic sampling. So systematic sampling basically says that I'm going to select every nth sample. Okay, so it could be every fifth sample, every 10th sample, every 15th sample, etc. Okay, so what I could do is, I'm just going to put everything on an Excel sheet, and then I'm going to just go about and select every the fifth one, the 10th one, then the 15th one, the 20th one, etc. Okay, that would be your systematic sampling. And finally, then you have cluster sampling. So cluster sampling basically just says that, within the population that I'm studying, I'm going to basically choose some divide that population into certain logical clusters. Okay, certain logical clusters. So for example, let's say I am going to look at you know health patterns, or basically fitness patterns of I'm just thinking out loud. Okay, of fitness patterns of IT professionals. Okay, let's say in the city of Boston. So what am I going to do? I'm going to look at some logical clusters. I would probably choose clusters like some IT companies that are situated in Boston. I'm going to look at those populations, and from within that, I'm going to choose some samples. Okay, so that is known as cluster sampling. Okay, so these are all examples of probability sampling. 4 types. So you have simple random sampling, stratified random sampling, systematic sampling, and cluster sampling. Now you have non-probability sampling. So the first type of non-probability sampling is what's known as purposive sampling. Okay, so purposive sampling is also called judgment sampling. So here what I'm doing is, as let's say I'm a healthcare quality professional, and I'm trying to study a particular disease or a particular condition, and I feel that for that particular study I need a certain kind of people. Okay, so I'm making a judgment about what kind of people I need to select from the sample. Okay, so so for example, what could be some, let's say I'm trying to study a particular clinical condition, and I feel that people of certain ethnicity would make more sense to have in the sample. So I'll go into the population, and from within that population I'm going to choose only some people from a particular ethnicity, for example. Okay, that would be a judgment sample or a purposive sample. Okay, it's based on my expert judgment. The second one here is what is known as convenience sampling. Okay, now what is convenience sampling? Basically, as the name suggests, it's basically whatever is convenient for me to choose as a sample. For example, let's say I'm going to conduct I just want to conduct a random sample in my community about, again, um, healthy lifestyle choices, for example. Okay, and just because because of my time and because of my work, I feel that on a weekend I can just go to a mall, I can survey some people. What I'm doing is I'm exercising convenience sampling. Okay, so I'm basically only looking at people who come to that mall on a weekend. So I'm excluding all those people who come to the mall during weekdays. Okay, so that's an example of a convenience sample. Then you have what is known as snowball sampling. Snowball sampling is also in some ways an example of a convenience sample. So why? Because snowball sampling basically says, let's say I'm conducting a survey, I conduct survey on two people, and then I'm going to ask them, okay, can you refer or recommend a few other people that I can survey? And they recommend a few names, and then I go out and survey them. Okay, so what I'm doing is I'm basically snowballing my sampling method. Okay, I'm choosing a reference. Again, sometimes you do this because sometimes it is very difficult to survey some kinds of people, or it's difficult to find volunteers for certain studies that you do. And so what you do is you basically find a few, and then you ask them if they can refer more, etc. So that's where snowball sampling is used. Okay, and you usually, why is it a non-probability kind of sampling? Because I am more likely to refer people or recommend people who are similar to me in many respects, right? So that's why it is a non-pro, because so there is that bias introduced there because of who I'll be recommending. And the final one is what's known as quota sampling. So basically what I'm doing is I'm, again, this is another kind of judgment that I'm making as an expert, or as a quality professional, or as a researcher. I'm going to decide that within that population, I just want to increase the representativeness of the sample. And so for this particular study, I need people from all different age groups. So I need X number of samples from who are below 20 years of age. I need Y number of people from between the ages of 20 and 40, and I need a Z number of patients between the ages of 40 and 60. Okay, so what I'm doing is I'm doing what's known as a quota sampling. Okay, so again, four types of non-probability sampling. You have purposive or judgment sampling, then you have convenience sampling, you have snowball sampling, and finally you have quota sampling. Good so far? Everyone okay? Okay. Now let's talk about measurement tools. So this is about the previous slides were about how do you choose the sample that you're going to study. Now, what are the tools that you're going to study the sample with? Okay. Now, what are some of the tools you can to collect data? You can use questionnaires, you can use surveys, you can use some rating scales, or you can use interview transcripts. You can develop an audit tool. You can develop some check sheets. Remember those check sheets and all that we talked about in our previous data webinar, right? All of those are measurement tools that you're using. Okay. Um, but mainly it's like questionnaires and rating scales, etc. Now when it comes to measurement tools, there are two important concepts. Okay, there is a concept of reliability and validity. Now let's spend some time on these two concepts, okay, because you can definitely expect a question on this. Reliability basically is about the consistency of the results that the measurement tools throws out at various periods of time. Okay, and validity is about the accuracy of the results that it gives. Okay, so now let me explain what that means. Okay, all right, let me just pause there. Is my voice okay? Are you able to hear me properly? No, no. Okay, just give me a second. Can you hear me now? Okay, how's the sound now? That okay? All right. Okay, so let's move on. Just to quickly recap, there are two concepts. There is reliability and validity. Reliability is about the consistency of the results that the measurement tool gives, and validity is about the accuracy of the results it gives. Okay, let me give you an example. Let's say I have a weighing scale at home. Okay, and let's say I'm 85 kilograms of weight. Okay, so 85 kg is my weight. I step on the weighing scale at 9 a.m. in the morning and it says 80 kgs. Okay, then I step on the weighing scale at 5 p.m. in the evening and it still says 80 kgs. Then I step on the weighing scale at 9 p.m. at night and it still says 80 kgs. That would be a reliable measuring tool. Okay, why? Because the results it gives are consistent, but it's not valid. Why? Because it's not accurate. You get the picture? Okay, that's the concept of reliability and validity. Okay, let's look at let's look at a simple example to try to understand. Let's say I have a dart board and I'm aiming darts at this board, and if you look at the first picture, what I have is I'm consistently hitting a spot, right? I'm consistently hitting a spot, but it is not the bullseye. Okay, so if I hit the bullseye, it would be accurate, but I'm not accurate. So what the first one says is I am reliable, but I'm reliably wrong, so I'm not valid. Okay, so this is reliable but not valid. Okay, now, so then what is this? Okay, this one is sort of all over the place. Okay, so what I have is, I mean, the validity is very low. It is somewhere around the bullseye, but it is, around the bull. It is not at the bullseye, so it's low validity and also low reliability because it's not consistently hitting a certain spot. Okay, then you have something that is hitting the bullseye and always hitting the bullseye, consistently hitting the bullseye. So that's both reliable and valid. And finally, you have something that is not reliable and not valid. Okay, does that make sense? Is the concept of reliability and validity clear of measuring tools? Yeah, okay. Okay, so now let's talk about measures of central tendency, and then we'll talk about measures of variation. So let's talk about measures of central tendency. There are three measures of central tendency. You may have heard this before in biostatistics if you've taken classes before. It's mean, mode, and median. So what is mean? Mean is the arithmetic average. Okay, so let's say you have 10 observations. Let's say I'm okay. Well, let's take this example. Okay, let's say I'm measuring the height of all the people on this webinar, and if I want to get the mean, what I'm going to do is I'm going to add up all the height, divide by the number of people. So let's say we have 9 people here. Divide by the number of people. That will give me the mean. Okay, so then what is the median? So median is the middle value. So in other words, if I take the 9 observations of height and I arrange them in ascending order and I choose the middle value, the value that occurs in the middle, that will give me the median. Okay, that will give me the median. Why is the okay, we'll come to that. And the third one is mode. Okay, the third measure of central tendency is the mode. And what is the mode? Mode is the most frequently occurring value. Most frequently occurring value. Okay, um, so why do we use generally, as you might remember, when we talked about run charts, we said that for run chart we use the median, not the mean. Why is that? Because the median helps us to overcome any the discrepancy in the data because of outliers. So what will happen is, let's say out of the 9 people in this group, 8 of us are round about the same height, but there is one person who is extremely tall, right? If you take the mean, it will skew the average that will give us. Whereas if you choose the median, it will give us a better picture, a more accurate picture of what the group is like. Okay, it will account for the outlier. Okay. Now you have measures of variability or variation. let's try to understand the concept of variation. Okay, let's say I have a class of students. Okay, let's say I have 100 students in my class, and I measure the heights for all of those students. And I'll get different numbers. There'll be some students who are short, some others who are tall. Okay, so what I'll have is, um, here I'll have a few students who are very short, and then I'll have a few students who are very tall, right? Somewhere around here, I'll have a few students who are very tall, right? And then I have a large number of students who fall somewhere in the middle. Okay, so I get this nice bell curve. Now, generally, it doesn't always give you a very good bell curve, but in theory, let's say you have a bell curve. So you have a large number of students who are grouped around the middle, and then you have on the two ends, on the two tails, you have some students. Okay, so this is the concept of variation, and this variation applies to everything. If I have a class of students and I give them a test, and then there'll be some students who will score very low, some students who will score very high, and a large number of students who will fall somewhere in the middle. Okay, this is that whole concept of a normal distribution or a bell curve, right? Now, so you have extremely low and extremely high, and then you have those sort of standard deviations, which we'll talk about in a bit, and then a large number of observations will be centered around the middle or around the mean. Okay, now let's talk about statistical tests. Okay, you might have heard about tests of significance that are applied in research projects, and there are a couple of tests that you might need to remember. Okay, I talk about these in detail in the CPHQ essentials as well, but here I just want to touch upon two that might be important for you. The first, what kind of statistical test do you use for continuous data? You use what's known as the t-test. What is continuous data? Remember, anything that falls on a number line, 0 to infinity. Okay, or it could be from negative to positive. Okay, so anything that falls on a number line, that you use a t-test. Okay, and if you have counts data like yes or no, alive or dead, pregnant, non-pregnant, okay, infected, not infected, those would be your counts kind of data. And for those, you use a statistical test known as chi-squared. Chi-squared. Okay, so just remember this. Usually I've noticed that sometimes there are some questions about what kind of, so they'll give you a scenario, and based on the scenario you have to make a judgment about whether this is continuous data or counts data. And then they will ask you, okay, what sort of statistical test would you apply? And then you just tell them, you can just answer saying it's either a t-test or a chi-square test. Now within t-test, there are two kinds. Okay, you have something known as a two-sample independent t-test and a paired sample t-test. Let me repeat that. Within the t-test, you have something known as a two-sample independent t-test, and you have a paired sample t-test. Okay, now what does that mean? Okay, just to quickly tell you, if I let's say I give a treatment to or let's say I conduct a survey, survey on some people. So for example, let's say I take the 10 people on this webinar, I split them into two groups. I train one group of people and I don't train the other group of people. And then I give tests, CPHQ tests to all of them, right? And then I want to compare if there is any statistical significance between the results for these two groups, okay? Now, in this case, what I will do is I will use what is known as a two-sample independent t-test. Why? Why is it independent? Because the interventions are different for both groups. One group got training, the other group did not get training. Okay. Now, imagine another scenario. I give training to all 10 on this group. Okay. And then what I will do is I'll do before the training, I will do a test, and after the training, I will do a test. Okay. And I want to compare the performance before the training and after the training, right? That would be an example of a paired sample t-test. Okay, why? Because the same intervention was done to both the groups, and I'm kind of testing the results of the pre and the post between these two groups to see if there is any significant difference. Okay, so that would be an example for pets. Just don't I know this can be overwhelming when you hear it, but just remember these concepts broadly. You will be able to figure it out. Just keep this concept in mind, that continuous data t-test and counts data chi-squared. Okay, now let's talk about the concepts of confidence interval and level of significance. Okay, now this assumes important when you're doing control charts and all that, and we will work out an example here after the slide, and it will become more clear for you. See, uh, so as I mentioned, you have this normal distribution, and the normal distribution says that you have some values that are extremely low, some values that are extremely high, that is a few values extremely low and extremely high, and a large number of values will cluster around the middle. So what they say is that you have these confidence intervals. Okay, um, so basically 68% of your these ones, the negative one and the positive one that you see here, these are the standard deviations. What is a standard deviation? So if I draw the mean, which goes right down the middle here. Okay, if I draw the mean which goes right down the middle here. Okay, see, the points are all clustered around the mean, they're all distributed around this mean. Okay, standard deviation basically tells me, on an average, what is the distance of each point from the mean. So let's say there is a point here, there is a point here, there is a point here, etc. So I can look at the distance of each point from the mean. Okay, and then I can sort of average it out, and that will tell me, like, what is the average distance of all the points in the sample from the mean. That is the concept of standard deviation. Okay, so within, what they have found is that within one standard deviation on either side of the mean, 68% of the points will fall. Okay, so 68% of your samples, if you go back, let's just go back to this slide, right? If you look at this, I'm looking at the height of all the people in my sample in my classroom, and what I find is that there is a mean height, and 68% of my students, their height will fall within one standard deviation. Okay, then 95% of my students' height will fall within two standard deviations, and 99.7% of my students' heights will fall within three standard deviations from the mean. Okay, so in other words, once I know the mean and I know the standard deviation, I can predict with accuracy about what will be, like, I can just pick up a student at random, and I can say with certainty about what his height will be. Okay, so that is the concept of confidence intervals. Okay, and the level of significance. So basically what it means is, the likelihood that any student in my group will have a height that is outside the 99 confidence intervals is very, very low. Okay, there is a less than 1% chance. Okay, so that is the concept of confidence intervals and levels of significance. Okay, all right, so let's I know this can be confusing, so let's just work out an example. Okay, a real example. So after studying Dr. Smith's process of patient encounters, we found, okay, that he spends an average of 19 minutes with each patient. Okay, with a standard deviation of 5 minutes. So this, we are studying how much time Dr. Smith spends with each patient. Okay, we found that he spends an average of 19 minutes with each patient, and the standard deviation is 5 minutes. So now what you want to do is, you are planning to visit his office today. Okay, and you want to get a rough picture of how much time you think you will be spending, how much time he will be spending with you. Okay, so, and you want to be 95% certain about how much time Dr. Smith is going to spend with you. How are you going to work this out? Okay, what is the minimum amount of time that he is expected to spend, and what is the maximum amount of time he is expected to spend? Okay, does that make sense to you? Does the question make sense? Yeah. Okay, so here's how we'll work out the example. Okay, so if you were to plot it on a normal distribution curve, We know that the average is 19 minutes. Okay, and you have a standard deviation of 5 minutes. Okay, so if you look at one standard deviation, okay, that means some patients, if the patients are within 68% of the 68% of his patients are seen within between 14 and 24 minutes. So he spends between 14 and 24 minutes with 68% of his patients. Okay, 95% of his patients have an encounter time of between 9 and 29. Okay, because it is a two standard deviations. Two standard deviations means what? Our standard, one standard deviation is 5 minutes, so two standard deviations is 5 multiplied by 2, that is 10 minutes on either side of the mean. Okay, so 19 minus 10 is 9 minutes, 19 plus 10 is 29 minutes. Okay, now if I were to go to three standard deviations, so that would be 5 multiplied by 3, that is 15 minutes on either side. So some patients get as little as 19 minus 15, which is 4 minutes, or they get 19 plus 15, that is 34 minutes. Okay, you get that? So basically, if you look at Dr. Smith's process, if you look at all the patients' encounter time with Dr. Smith, you find that some patients get as little as 4 minutes, some patients get as little as much as 34 minutes, but the average is 19 minutes and the standard deviation is 5 minutes. Now for you want to be 95% certain, right? That is the amount of certainty you want. So since you want 95% certainty, how many standard deviations would you choose? Okay, Sarah says 2. Anybody disagree? Okay, where's everybody else? Did I just lose you? Okay, all right. So because you want 95% certainty, you will choose two standard deviations. That means now you know that he will spend a minimum of 9 minutes with you or a maximum of 29 minutes with you. Okay, that's how much certainty you want. Now, how do you decide? And I'm just going to introduce this concept to you. See, in healthcare, there are some processes for which you need a lower level of certainty, and for some others, you need a higher level of certainty. Okay, for example, for waiting times in a hospital, your certainty can be low. You can just choose a 95% certainty. But if you're looking at, let's say, medication errors, okay, or accuracy of medication, would you want a low level of certainty or a high level of certainty? You'd want a high level of certainty, isn't it? Yeah. So in that case, for those kind of high risk, high alert processes, you would use a higher level of certainty. So you would want to look at 99% certainty. Okay. So that would be within 3 standard deviations or 3 sigma. The sign you see there, the mu sign you say in there, that is the sigma sign. Okay. So 6 sigma basically stretches this out to 6 standard deviations. Okay, so the process becomes so tight that anything that falls outside the 6 sigma is considered to be an error, or it is considered as a fall or bad sample, right? So the likelihood, see, think about that, right? 99%, 99.7% of your sample falls within 3 standard deviations. When you take it out to 6 sigma, it goes even further, right? So 99.999 something percent falls within 6 standard deviations. So the likelihood of error will be that much smaller. Okay, that is the concept. I just wanted to introduce that to you. So was this example helpful? Did you understand the concept? Okay, great. All right. So let's move on now. Now let's talk about some charts. Remember, on our data webinar, we had talked about the concept of run charts. There is another, what you can do with run charts is you can actually stratify your run charts. Okay. So for example, let's say now here, I am looking at maybe some patient satisfaction responses. Okay, patient satisfaction responses, and what I can do is I can get responses for the entire medicine department, for example. Or what I can do is I can break it down by different units. So unit A, unit B, and unit C, and I can look at the responses for each individual unit. Okay, so stratification chart helps you to do that. So within the same chart, you can actually it can be a run chart or a control chart. You can stratify your data according to different units, and you can observe your data. So that's what a stratification chart is. The other different kinds of charts I have actually explained in detail on the CPHQ Essential, so I'm just going to spend time on some important ones and some updated ones. Okay, and the rest of it they've been really well explained on the CPHQ Essentials course. Okay, again, what kind of control chart do you select depending on the type of data? Again, this, you may get a question on this concept, but don't confuse yourself, don't spend too much time on this. It's important important to just to know. Okay, I'm just looking at a question here. So Sarah says, what do we do next if there is a signal on a run chart? So Sarah, so you're talking about the four kinds of signals that you can get on a run chart if there is some significant event happening. So that is a management decision or a healthcare quality professional's decision. Okay, so if you see some unusual results, you need to have some intervention in place. And that intervention could be anything. You could be educating your staff, you could be training your staff, you could be introducing some sort of an error-proof system, you could be introducing a checklist, you could be introducing some inspection process. It could be any of those interventions. Okay. So you say immediate step. I don't think I understand what your question is. What do you mean? Okay. So selecting a control chart, let me just waiting for Sarah to respond, but um, what do we need to do to repeat the median? Um, Well, actually, just that is exactly what I said. Like, if you're using the median, just one significant astronomical point is not going to change your median a lot. In fact, you do not change your median with every new data point. Okay, once you do an intervention or an improvement initiative, you wait for that to take effect over a period of time. Only when you think that your data is kind of improving on a consistent basis do you select or create a new median. Okay, so you don't change your median often. Okay, so coming back to control charts. So depending on what kind of data you have, whether you have counts data or measurement data, which is attribute or variable data. If you have variable data, depending on your sample size, you have different kinds of charts. Just remember these names because going into the details of this would be really confusing, and you don't actually need it at the level of your CPHQ exam. Okay, just go through this chart once or twice. Okay, now let's move from data and talk about how to make data-driven decision making. It's a role of the healthcare quality professional that you present the data in a way that helps understanding for your leadership as well as for your team members and your staff, and so that appropriate action can be taken. Okay, and to do that, it's very important that you know how to display your quality and performance improvement information. There are some rules. You should provide some contextual background. What is this project about? What is the purpose of this measure? Why are you doing it? What are you trying to improve, etc. Okay, always be thinking about how to best depict it graphically. So this is where you will need all kinds of charts. The hallmark, the mainstay of quality improvement is run chart or a control chart. Remember, okay, explain how you collected the data so that people don't raise concerns. You should always have a summary report depending on what level of leadership you are giving that the information to, and also have a statement about what you did with the outliers. Okay, how as an organization, what is your policy for dealing with the outliers? And what was your time order for data collection? Okay, when did you collect this data? Is this data relevant and current and up to date, etc.? Okay, now you might have heard the term balance scorecard. This was introduced by two people known as Kaplan and Norton. It was used in the industry basically. So it's a way of displaying your performance measures so that you get a holistic view, okay, an all-round view of the performance of your organization. So in other industries, basically they look at the financial performance, they look at performance of your core system processes, they look at any learning and growth measures, and they look at human resource measures, etc. Right? So that is a balanced scorecard. Okay, it's basically a framework. It's a way of reporting the most critical metrics that your organization tracks, and it must represent like I said, a holistic view of your business or of your operations. Okay, and here you're also going to compare yourself to some targets that you set. And it's a very visual, easy tool for communicating your quality measures to your leadership team, to your board of directors, etc. Okay, this is an example. This is our balance scorecard in clinical care setting will look, in a hospital or a healthcare organization will look. So you basically have some measures about your clinical quality of care. You will also have some measures from your customers, so patient satisfaction surveys, patient experience, etc. Then you will have some operational measures, so readmission, length of stay, waiting time, turnaround time, all of those would be operational measures. And then you have some financial measures as well, like what was your revenue, what was the amount wasted, how many resources were there, what was your growth, etc. Okay, so what this does is it gives you a very, very overall comprehensive view of how well your healthcare organization is performing. Right. Now, another key tool that healthcare quality professionals must be aware of is to present this information in a dashboard. Okay, so when you work in a managerial capacity or you move up in leadership in quality, you must be very well versed with dashboards. So what it does is it represents key management and performance indicators in a visual manner, and it's basically a decision support tool. Okay, you look at those measures, it helps you to analyze your current performance, and it will help you to forecast your performance into the future, and it will also help you to monitor how well your systems are functioning. Okay, and you can also, one good practice is to incorporate some external benchmarks. Okay, so these benchmarks can be collected from your region, from your state, from your country, etc. Okay, and this is an example of a great performance dashboard. So the leadership can look at some key metrics. See, you have length of stay metrics, you have admission and readmission rate, average treatment, what kind of payers are there and how many stays they have, what is the nurse patient ratio. So in a snapshot, in just one single slide, and I look at the dashboard, it sort of gives me the pulse of my organization. Right, that is the use of a performance dashboard. Okay, so Sarah has asked, can you highlight the difference between a balance scorecard and a dashboard? So balance scorecard basically, Sarah, generally alludes to four main indicator types. Okay, because that's how the theory of balance scorecard came about. So you will have metrics about your customer, which in our case is the patient. You will have metrics about the system performance. Okay, you will have metrics about financial performance, and you will have metrics about learning and growth. Okay, so that's the so balance scorecard in some ways is like it's set, it's a set pattern, but performance dashboards, it's very, very similar to a balance scorecard. It's just that you choose what measures you want to put on the performance dashboard. Okay, and it's like looking at the dashboard on your car. In one glance it will tell you what is your speed, what is your mileage, it will tell you how many kilometers you've traveled, it will tell you if your fuel is on empty or full, right? So you choose which measures you want on your performance dashboard. So in that sense, that is the key difference between a balance scorecard and dashboards. Okay, like balance scorecards are more they're already set, and then performance dashboards you choose, you can tweak according to your priorities, on your strategic priorities. Make sense? Dashboards, so the question is, do dashboards depend on specific initiatives? Dashboards depend on your strategic priorities. What do you want to track? What is important for the leadership to know? What is important for your organization's performance? What is important to your customers? Right? It depends on that. Okay. Another example, this is from another organization. So here they think that patient satisfaction scores are very important to have on the dashboard. The lab test turnaround is very important. They want to track patient falls. Probably it's a priority. See, again, why do you think this organization might have decided to have patient falls as one of the key things that they want to measure? Perhaps there have been some incidents in the past in their hospital where patients were significantly harmed because of falls. Okay, so maybe that's why they decided that it's an important improvement priority for them, so they decided to track it as a critical measure on their dashboard. Okay, and then you have oops, yeah, then you have average waiting times, right? And it's very visual, right? It's very visually displayed. It's very easy for people to read and understand it. Okay, now let's talk about the concept of benchmarking. Whenever you're using performance measures and you're developing dashboards, it's important to compare yourself to other systems, right? So you need to have comparing indicators that could be like structure measures, process measures, and outcome measures. You can compare them against best performance. Okay, and this is also you do so that you can seek out ways to make improvements with the greatest impact on outcomes. Okay, how do you compare? There are different kinds of measures you can use. You can use efficiency benchmarks. Okay, so this efficiency benchmarks basically tell you about the cost efficiency, the cost effectiveness of your performances. The financial performance angles, so you can compare them against how efficient you are compared to other organizations. Okay. Then you have quality benchmarks. So these would be related to how well you are managing the variation um, of your clinical care that you provide to your patients. Okay, so are you able to control the variation or the variability in the care that you provide to different patient groups? Then you have administrative performance benchmarks. So this could be related to your financial performance. It could be related to human resource performance. Okay. Now, what are some sources from which you can collect data for benchmarking? The government has a lot of data. You can compare, government collects data like, the CMS, etc., collects data from across the country in the US. And so you could compare your performance against whatever data the government has. If you're part of big alliances of large healthcare systems, you could compare your hospital against other hospitals in your system. You could also get data from state peer review organizations or state hospital associations so that you can compare yourself to other hospitals in your region. Okay, or you could also get some data from database companies, okay, that can provide you the data. Okay, then you have the concept of internal benchmarking, which basically, let's say you can compare the performance of one unit against another one. Okay, so I can compare, let's say, my central line infection rates in my unit compared to the central line infection rates in some other unit in my hospital. Okay, now it can be done quickly because it is within my system. It can be done very quickly. It is less expensive and it offers learning for everybody in the system. Right, I can share my learning with others. Others can share their learning with me, etc. And you can also do a physician to physician comparison. You can do a unit to unit comparison, like I mentioned. Okay, and versus external benchmarking. So external benchmarking is where I compare my healthcare system to some other healthcare system. And the basic challenge is looking at the specificity of the indicators, right? Like how do I make sure that the indicator that I'm using, uh, the way I am measuring it, is the same as the way some other hospital is measuring it. Okay, so I need to be sure about whether they both are comparable or not. Right, and you can also compare yourself against other healthcare organizations, against the national database, looking at similar size hospitals, etc. Remember, again, here the concept of risk adjustment and severity adjustment plays a key role. Right, okay, so that brings us to the end of health data analytics. um, Okay, so I see some questions here. So Sarah is asking, are dashboards made on department level or organization level? So typically, Sarah, dashboards are made at both levels. Okay, so you have department level dashboards and you have organization level dashboards. So for example, let's say a hospital may choose. Okay, so let me give you an example. Okay, let's say I have three departments in my hospital. I have a medicine department, I have a surgery department, and I have an ED. Okay, all three of them can have their own dashboards and they can choose what sort of indicators or measures they want to have on those dashboards. Then I have my hospital's overall dashboard, and on that dashboard my leadership team will decide on like having a couple of key indicators that looks at system level performance, and they may also choose one indicator each from my surgery department, from my medicine department, and from my emergency department. Okay, so the answer to your question, they can be on both department level and organization level. Natasha is saying balance scorecard can be shown in the form of a dashboard too. Absolutely, you're right. Basically, yeah, it's again it's a visual display. Balance scorecard is also shown as a visual display. Yes, so it can be as a dashboard. Okay. Any other questions? Okay, so what I'm going to do now is I am going to quickly um, go over to a couple of questions that Sarah had sent me by email. Let me look at this. Let me get this question here. All right, so here's a question that Sarah had sent. You all can read it. It says an organization-wide electronic medical record system was recently implemented in an acute care facility. Nurse in hold on. Nursing staff in the intensive care unit found the electronic reports that were generated more difficult to read than the previous paper-based ones. What should they do first? Report the issue to the EMR project team, attempt to find a solution in the ICU, wait to see if the EMR project team will provide an organization-wide solution, or recommend that the ICU uses paper-based reports only. What do you think the answer is? What should they do? Okay, so I got one answer, A. So Sarah says A, May says A, Natasha says A. You're right. So the answer is A. Because the first thing that you do is that you have to report. It could be a technical error that can be easily fixed, and therefore you will report it to the EMR project team. You will not attempt to find the solution in the ICU because that would be considered a workaround, and there are patient safety issues with it. Okay. C is wait to see if the EMR project team will provide an organization-wide solution. Remember, you are in the ICU, and so you don't have the luxury of waiting for the EMR team to come up with a solution. You would have to be proactive. And obviously, D is straightforward, a wrong answer. You cannot recommend that we go back to the paper-based system because a change has already been made, and so you need to make it work. Now, Sarah says on CPHQ tutor, the answer was B. Well, Sarah, I don't think that would be right because you would not do that. You would not workaround is never encouraged. Okay. Okay, so Natasha is asking, could I know where this question is from? Is there a question bank? So Natasha, Sarah has another online source that she's using. This is not part of what I am giving. So, this is a question she found online elsewhere, and she had asked me about it. Now, a word of caution. Some of the questions that I've been getting, in my experience, they are not very representative of the questions that you usually get on the CPHQ. I've said this before. You could get a lot of questions online, but some of them are straightforward. They are not the kind of questions you get on the CPHQ. Case in point, look at the second question here. Okay, consider a 4-step treatment process with yields for each step. Okay, so basically you have, let's say there is a treatment process. So step 1 happens, after that step 2 happens, after that step 3 happens, and after that final step, which is the first step 4 happens. So when you say a yield, what it means is that, let's say I put 100 samples through the process. After it gets done with step 1, 99 of them are accurate and there is one error. Okay, so that means it has a yield of 99%. Okay, so I would have to discard one sample. Then after step 1, it goes through step 2. Okay, out of those 99 samples, 95 I get a 95% yield. That means 95% of the 99 are accurate, and there are the rest 5% are errors. So I throw those out. So I now get 95% of the 99, and so on and so forth. Okay, so that is the concept of yield. Now, so the question here is, on an average, what percentage of the organization's efforts in this process requires rework? Okay, so you're trying to understand how much, what is the error in it. Okay, so you have to get the overall yield first. How do you get the overall yield? You basically multiply the yield for each step. So you have 99% multiplied by 95% multiplied by 95% multiplied by 94%. Okay, you multiply the yield for each step, and that will give you the overall yield of the process. So it's basically 0.99 multiplied by 0.95 multiplied by 0.95 multiplied by 0.94, and that will give you 0.8. Okay, or basically it gives you 83.9% or 84%. Okay, 84, that means 84% accuracy. The remaining samples will require rework, right? So 84% of the samples can be accepted, 16% of the samples cannot be accepted, and it will require rework. So the answer here is D. Okay, did that make sense? You all clear on the concept of yield? Yeah. See, to be honest with you, I don't think CPHQ exams would require you to do calculations, right? Complex calculations. Usually, they will only give you calculations that can be easily done with a paper and pencil. Now, this particular calculation, I had to use my calculator for doing it. Yeah. So Sarah, you're saying, but yes, but isn't it too complicated? Exactly. That's my point. So, my experience is that CPHQ doesn't actually require you to use a calculator and do all those complex calculations and all that. Okay. But I just, now you get the concept of a yield, and based on that um, you can like do, so that's why I'm always adding this word of caution. Don't trust all these questions that you find from different sources on the internet. Okay, and don't overwhelm yourself, don't stress yourself out because you're not able to answer these questions. Now look at the next one. This is even funnier. uh, Hold on. Oh, so you had 4 questions. Okay, so the next question is, the current error rate is 1 per 1,000 pharmacy orders. The hospital has 200 acute beds plus an outpatient service. The number of pharmacy orders is 2,000 orders per month. Trial of a handheld device is planned. Analyst recommends a sample of 3,000 pharmacy orders for the trial. The 2 patient care units being tested generate about 1/3 of the total pharmacy orders each. How long will the trial take? Now see, um, this one is, to be very honest with you, this is a straightforward math question. It is not a CPHQ question. Okay, this is more like the math question you get on maybe in an 8th grade. Okay, I'm really not sure that you get these kind of questions on the CPHQ, right? So to answer your question, the answer here is 10 weeks. Okay, it's 10 weeks because if you do the calculation, you will find that you will be able to do the trial in two months, 2.25 months. Okay, which is 10 weeks. But I don't need to be a qualified healthcare quality professional to answer that question. I just need to know high school math. Okay, so again, this question I don't think is very representative of the kind of question you get on the CPHQ. Okay, final question. Um, The accounting system of an organization has an error rate of 25 errors per million transaction. Again, this is a question about yield. Okay, error rate is 25 per million transactions, and there are 200 accounting transactions in the typical patient record. The treatment stage has an error rate of 7 per million opportunities, and there is an average of 500 opportunities. So what is the process yield considering both accounting and treatment? Again, this is a question about yield. All you need to know is the error rate. So error rate for the first one is 25 errors per million. The error rate for the second is 7 per million. So you can calculate the error percentage, and then if you subtract it from 100, that will give you the yield percentage, okay, for the accounting process and the treatment process. And then if you multiply both, that will give you the overall process yield. And I think I calculated it to be about 99.9%. But again, I don't think these kind of complex calculations are asked on the CPHQ. I could be wrong. I'm just saying it because you never know, some centers, but it would be highly unusual. It would be highly unusual. Okay, to do these kind of calculations on the exam. Again, these are all math calculations, and I don't know what use these kind of complex math calculations have for a quality professional. Basically, you should know the concepts, and you should know how to apply the concepts to help the leadership. That is your job. All right. So that's it. With that, we will come to the end of this webinar, and I hope you got some value out of this webinar. And feel free to write to me if you have any questions. Any final thoughts or comments? Was the session helpful? Yes, you guys are most welcome. And I know Natasha says I'll need to do it a few times over. That's right. Data is always a challenge for all of us. So definitely, but I'm sure you'll once you go over it a few times, you will get the concepts. Okay. So with that, I will leave you to take care of the rest of your day. Have a good rest of the week, and I will see you. Basically, I'll talk to you again on Saturday for our third module. Okay, so you have a good afternoon, good evening, and good night. See you again. You guys are most welcome. Thank you very much. Bye. Bye-bye.